Hi everyone, and welcome to our second module on skin disorders. Let's start by talking about erythema nodosum. This is an example of a type 4 hypersensitivity reaction, meaning it is basically an allergic reaction in which the body attacks itself. It's a form of paniculitis. Paniculitis means inflammation of fat, and in this case it's the subcutaneous fat in the skin. So by way of review, the skin has an epidermal layer on top, and then next it's got the dermis, and then below that it's got the subcutaneous fat. And this is the layer that becomes inflamed due to a hypersensitivity reaction in erythema nodosum. Often this disorder is idiopathic, but there are a number of triggers that can potentially lead to this. These are all things that ramp up the immune system, potentially causing a hypersensitivity reaction. So infection is the most common trigger. Usually it's a strep infection. This can also be triggered by Crohn's disease in some cases, and there are many people in whom an episode of erythema nodosum precedes a flare. So they will develop this skin disorder, and that means that they're about to get a flare of their Crohn's disease with GI symptoms. And then erythema nodosum is also associated with sarcoidosis and coccidiomycosis, the fungal infection. Erythema nodosum causes painful red nodules on the skin, most commonly in the shins. This is a picture of someone with erythema nodosum on the screen here. On the right, I've zoomed in on a lesion. And the word painful is key, so there are other things that can look like this, but they tend to be itchy or have other clinical findings. If a person with one of the triggers I talked about in the last slide has an eruption of painful red nodules on their shin, erythema nodosum is one of the things you should think about. The classic pathology finding on biopsy is septal paniculitis, so let's talk about what this means. Paniculitis, as I told you, means inflammation of the fat, and in this case, it's inflammation of the septa of fat between the dermis and the fascia. So if you look at this picture on the screen here, these white lobules are fat. What's inflamed are the septa in between the lobules, not the lobules themselves. That's called septal paniculitis. And this is in contrast with lobular paniculitis, where the fat lobules are inflamed. That occurs in other disorders. Our next disorder is lichen planus. This is a rare chronic inflammatory skin disorder, and if you don't know this, the word lichen means tree moss. This is a picture of a tree with lichen on it, and the word planus means flat. So this disorder gets its name because it is a flat skin lesion that reminds people of tree moss. It occurs in adults. The pathogenesis is unknown, and it resolves spontaneously, although it takes years. And in terms of board purposes, you should know that this is classically associated with hepatitis C. This will often be described in a patient who has chronic hepatitis C infection. Many books will tell you that the symptoms of lichen planus can be remembered by the 6 Ps. Those Ps are pruritic, purple, polygonal, planar, papules, and plaques. Personally, I've never found this that helpful. How I always remember this is that these are purple, flat lesions that are very, very itchy, often intensely itchy, and this is a key clinical finding, especially in board questions. Like I told you before, erythema nodosum and other disorders can be painful. In the case of lichen planus, it will be itchy. The lesions tend to be multiple and symmetric. They're often on the arms, legs, or wrists. The wrists and ankles are classic sites. And this is a picture of someone who has lichen planus on the screen here. It's not very distinct. This looks like lots of other skin lesions. The way you're going to recognize this in a board question is that it will probably be in a patient with hepatitis C, and it will be very, very itchy. Some other clues that can help you recognize this disorder in a board question are that it often has mucosal involvement, often in the mouth or on the tongue, sometimes on the glans penis. This is a picture of someone with mouth involvement. And if you look closely at the lesions in lichen planus, you can see these white dots or lines. They're very easy to see in this picture on the screen here. Those are called Wickham striae, and they're caused by hypergranulosis, which is a classic feature of lichen planus that I'll talk about in a minute. The striae are often best seen on the oral lesions, like in this picture on the screen, although if you look closely at the skin lesions, you can sometimes see them as well. So once again, in a board question, if they describe these white dots and lines of Wickham striae, you should think of lichen planus. Let's talk about what you would see under the microscope if you did a biopsy of a lesion of lichen planus. First of all, what you would see are lymphocytes at the dermal-epidermal junction. This is the dermal-epidermal junction here, and you find lymphocytes there in a lesion of lichen planus. Second important finding is hyperkeratosis. That's increased thickness of the stratum corneum. Lichen planus is the classic disorder to cause hypergranulosis, and I talk about this in more detail in the video on the skin, but hypergranulosis is increased thickness of the granular layer of the epidermis. And then finally, a classic finding in lichen planus is the so-called sawtooth pattern of the Rete ridges. Rete ridges are these portions of the epidermis that dive down into the dermis. They're between the dermal papillae, like this one here and this one here. And you can see that these form sawtooths, like this one I'm marking with my pen, and this is called the sawtooth pattern of the reed ridges seen in lichen planus. Moving on, let's talk about pityriasis rosea. This is an acute self-limited skin rash. People with this disorder have an eruption of skin lesions that is self-limited and usually goes away in about 2 to 3 months without any treatment required. The cause is unknown, but it's believed to possibly be caused by a virus. Pityriasis begins with a skin finding called a herald patch. This is a single red salmon-colored lesion that is round or oval and well demarcated, usually on the chest, neck, or back. This is a picture of one right here on the screen. This is a herald patch here in the middle of the image. Days later, multiple lesions develop on the trunk. These are similar to the herald patch, but they're smaller. They're usually grouped together, and they follow the lines on the skin. And since the lines on the skin, especially on the trunk, like for example on the back, tend to go like this, it is said that these lesions tend to form a Christmas tree distribution. So here's a picture of the back of someone with pityriasis rosea, and you can see these red lesions here, and they tend to follow lines like this going down this person's back on both sides, and so people think this reminds them of a Christmas tree. So the classic example of this in terms of board exams is someone who has a herald patch followed by multiple lesions on their back or trunk in a Christmas tree pattern. It's self-limited and usually resolves in a few months without treatment. Now let's talk about burns, which refers to thermal injury to the skin. And one way to classify burns is based on the depth of the injury, meaning how many layers of the skin are involved. If you look at this table on the slide here, I've described the depth of the injury in this column and the skin layers that are involved in this column. And in the middle, I've listed the degree of the burn. So we used to describe burns as first, second, or third degree. This is still often used in clinical practice, although the preferred way to describe them now is based on the depth of the injury. So a superficial burn is also called a first-degree burn, and this involves only the epidermis. Superficial partial thickness burns and deep partial thickness burns both used to be called second-degree burns. They both involve the epidermis and some portion of the dermis. More is involved in deep partial thickness burns. And I'll talk about the distinction between these two types in just a minute. And then a full thickness burn used to be called a third degree burn. This involves the epidermis and the dermis. And then finally, the term fourth degree burn is still used to refer to any burn that involves the entire epidermis, dermis, and underlying tissue. So a first degree burn or a superficial burn involves the epidermis only. You can think of it as a variation of a sunburn. It's very similar, and we'll talk about sunburns later in this video. Superficial burns are painful, and they're red, and they blanch with pressure. So the reason this burn is red is because there's more blood flow to this area. And so when you press down with your finger, you cut off the blood supply, and the skin will blanch or become white. As I said, it looks like a sunburn. Importantly, it has no blisters. If blisters are present, it's a deeper form of burn that we'll talk about in a second. And these usually heal within a week, and minimal treatment is required. A superficial partial thickness burn used to be called a second-degree burn. This type of burn injury involves the epidermis and some of the dermis. And this type of burn injury often forms blisters. You can see on the slide here there's a blister right here. There's also a red area here similar to a first-degree burn, but the blister distinguishes this as a superficial partial thickness burn. These types of burn injuries are painful, and they can be red, like this area of the skin shown here, and they blanch with pressure similar to superficial burns. And usually these take a little bit longer to heal, about 7 to 21 days. Deep partial thickness burns also were called second-degree burns in the old system. These burns involve the epidermis and most of the dermis. They can be erythematous and red, but often they are yellow or white. If you look at this picture of a deep partial thickness burn on the screen, you can see this white area here. That's typical for this type of burn. These burns almost always blister, but the blisters are often easily unroofed and the tissue can move. So for example, if you look on the screen here, you can see the blister of this burn. The tissue has been pushed aside from the burn injury area. It's super high yield to know that these types of burns are painful to pressure only, and this distinguishes them from superficial partial thickness burns. These burns also do not blanch, which is another distinguishing feature. They usually take more than 21 days to heal, and these burns often heal and leave scarring behind. And then finally, full thickness burns used to be called third or fourth degree burns. These burns involve the entire epidermis and the dermis, and they can also involve the underlying tissue. And so when the underlying tissue is involved, they're called a fourth degree burn. So this is a picture of a third degree burn here at the top of the screen. This is a fourth degree burn down here. You can see that the tissue of the fingers is damaged. Underlying tissues like fat, fascia, or muscle can be involved. And the key thing to know about these types of burns is they're entirely painless, including to pressure, and that's because all the nerve endings have been destroyed. And these burns heal with scarring, and sometimes the wound contracts, and surgery is required to manage the wound around the skin to keep it from contracting and causing further problems. I'll finish by talking about sunburn. Sunburn is a delayed inflammatory response of the skin caused by ultraviolet radiation, usually from the sun. It's a delayed response, meaning that you're exposed to the sun, but you do not develop the inflammation until a number of hours later. And there are two forms of UV radiation. The first type is called UVB radiation. The reason it's called UVB is because it has a wavelength from 280 to 320 nanometers. The second type is called UVA radiation. This has a longer wavelength, 320 to 400 nanometers. Both may cause sunburn, but UVB range is the most effective at causing sunburn. This is something high yield for you to know for your boards. It's usually the UVB range radiation that is most damaging to our skin. In sunburns, there can be damage to the epidermis or the dermis. It depends on the severity of the burn. In minor sunburns, the damage is usually limited to the epidermis. In severe sunburns, the dermis can be damaged as well. The pathology involves UV radiation causing DNA damage, which leads to apoptosis. And you want to remember that apoptosis is involved here. This is the kind of thing they like to ask you about in step 1. In fact, under the microscope, you can sometimes see what are known as sunburn cells. These are keratinocytes that are undergoing apoptosis because of DNA damage. In addition to apoptosis, vasodilation occurs, and there's release of inflammatory mediators. The skin will turn red, like this man shown on the screen here. And as you probably know, if you've ever had a sunburn yourself, this is usually a self-limited problem that resolves on its own within a day or so. And that concludes our second video on skin disorders.